Okay, welcome everyone. I think we'll go ahead and get going. We'll likely have a few people continue to join us, but so we can maximize our time, let's go ahead and get started. So again, welcome everyone to this year's first quarterly Geohealth webinar. Really quickly, just to inform everyone, we are recording the session. So if you would prefer not to have people be able to see your video, just keep your video off. Otherwise, we're happy to see everyone's faces. Just a little bit of information. Geohealth is going to start presenting seminars basically on a monthly basis. So we will hold joint general body webinars with covering a variety of topics, and they will include a post segment for early career researchers. And then pretty much most of the other months, there will be one that's specifically directed towards early career researchers. So watch for the announcements as we send them out over AGU Connect. And again, please feel free to get in touch with any of us if you have some topics that you think would be great to cover. Okay, so for today's agenda, I will take a minute and introduce the presenters for today, and then after that, two of my colleagues during that time will be looking at the question and answer section so that we can keep track of that. And then Andrea Hess will be the moderator for the question and answer session. And then after that, we'll allow people to stay on if they'd like for the early career portion, or they can just leave if they choose. So today, again, we're having Dr. William Pan and Dr. Ben Zajac to present some of their work with us. They'll be describing their collaboration in developing a malaria risk warning system for parts of the Amazon. So Dr. Pan is the Elizabeth Brooks Reed and Whitelaw Reed Associate Professor of Population Studies and Global Environmental Health in the Nicholas School of Environment and Duke Global Health Institute at Duke University. He is a biostatistician and he's trained in infectious disease epidemiology and demography. He leads research that addresses population health and environmental dynamics, including artisanal gold mining, mercury exposure, land use changes, and malaria. And his work is primarily taking place in low to middle income countries in Latin America and the Caribbean. So Ben Zajac, in addition to serving as our current president of our Geohealth section, is also a professor in the Department of Earth and Planetary Science at Johns Hopkins University. He's primarily an earth scientist, and he works with atmospheric and hydrological processes and applies these to problems related to water resources, agriculture, and of course, public health. So this health focus that he has includes the development of early warning systems that are informed by the environment. So he looks especially at infectious disease such as the malaria system that will be discussed today. So I'll go ahead and stop sharing my screen and turn the time over to Dr. Zajac and Pan, and we'll go from there.
Thanks, Jen, for that introduction. I think the way Ben and I are going to be organizing this is I am going to be sharing the screen and driving the presentation that we're giving, but we'll be going back and forth on the presentation. I did want to mention, though, that Ben and I have been working together since about 2009 or 2010, somewhere around then. We were both at, I was at Hopkins at the time in the School of Public Health. And I would just say for anybody starting out in your new career in a university or any kind of research setting, one of the things that I find very important for a young scientist is making sure you go around and meet as many people as possible. Hopkins is not necessarily set up for Ben's department and the School of Public Health to collaborate. They're miles apart, and probably a 20-minute bus ride But you know, it definitely has paid off in our collaboration, and I know that I'm really thankful for it. And Ben can say whatever he else wants about our collaboration. Maybe he's regretting our collaboration. All right, so I'm going to talk about our early warning system work, and basically this is a huge team that has been working on this project. Not everybody on here is probably listed. We're probably missing several folks, but basically Ben and I started this with a postdoc who was shared between us, Beth Feingold, who's not listed, but she's in the photo, back in about 2009 or 2010 when we got a feasibility study from NASA to figure out whether or not we can even develop a system for detecting malaria using remote sensing or other types of modeling tools. So what we're going to be talking about are some of the challenges we've had, some of the successes we've had, but I didn't know what everybody's background was on malaria. So basically, we're going to just start out by talking a little bit about what malaria is, how surveillance is conducted, particularly in the Americas where we work. And then I'm going to hand off some of the stuff to Beth and then to Ben, and then we'll go back and forth on some things. So what is malaria? I'm sure everybody knows, since we're inundated with infectious diseases these days. You probably know that malaria is a vector-borne disease. You probably know that it's spread by a bite of a mosquito. You might not know, if you haven't taken an epidemiology class, that mosquitoes actually get infected by biting infected people. So mosquitoes have to get infected. They have an incubation period within their bodies before they're able to transmit again. But there is this really nice diagram from CDC that kind of describes the life cycle. So a human, for example, has malaria, a mosquito bites the infected person, and then the parasite goes through a reproductive stage within the mosquito, and then on its next blood meal, which is roughly 3 to 7 days later, can bite an infected person, or bite a person and infect them with malaria. There are generally 4 or 5 different Plasmodium species. Whether or not you consider Plasmodium noloesi as a human malaria species or a human malaria parasite or not, I think it now is classified as a human malaria parasite. The ones that we worry about most globally are Plasmodium falciparum and then Plasmodium vivax. Plasmodium falciparum is the species that causes the most death, probably about 95% of deaths worldwide, and primarily exists in Africa. Whereas Plasmodium vivax, which is the second most important, exists mostly in South America and South Asia. Although there are pockets within, say, the Americas that have a high number of falciparum cases, like in Haiti, and there's places in South Asia that have a high number of falciparum cases as well that people deal with. Just so you know, in malaria, the impact, it's endemic in over 100 countries. About 3 to 4 billion people are considered at risk. In 2018, there were between 200 and 300 million cases. We don't have an exact number because these are basically estimated based on different surveillance systems that operate at different levels of capacity and accuracy. I will say that most of the malaria occurs in sub-Saharan Africa and India, and most of the deaths are occurring in Africa. And almost all of those, by the way, as I said before, are due to falciparum malaria. So in the Americas, there has been tremendous progress over the last 20 years in reducing malaria rates. So these lines are hard to distinguish the countries, but it doesn't necessarily matter. This big red line is Brazil, and then this green line right here is Venezuela. But basically what you want to notice is that since about 2005, there has been a strong downward trend in malaria cases. However, if you look at the number of cases that have occurred since 2010 and 2011 until now, the Amazon is one of the only regions of the world where there has been a very rapid rise in cases, over 700% increase in cases, driven a lot by what has occurred in Venezuela, but also, which you can't see in this particular slide, things that are occurring in countries like Peru and Ecuador that are having problems with controlling malaria for different reasons. So here's just 3 different countries, Colombia, Ecuador, and Peru, showing the trend from 2008 to 2018 in malaria cases. And just to point out, Peru was almost near an elimination phase back in 2010 and 2011. And it was interesting because at that time, I actually had a lot of discussions with folks about whether or not I should move out of Peru, the malaria work, because if they eliminate it, then there's not really a need for having any kind of research going on there with malaria. But of course, since 2011, there's been this rapid increase. And some of the reasons why we observe these increases across these 3 countries include a massive withdrawal of funding from the Global Fund. So there's something called the Global Fund to combat HIV, tuberculosis, and malaria. And the Global Fund has actually stopped all funding for malaria control in South America, except in Suriname and Guyana. Or, I'm sorry, in South America, except for Suriname and Guyana. It ended in Peru in 2011, ended in 2014 in Ecuador and Colombia. There's also been massive floods that different countries have dealt with. There's been ongoing deforestation because of resource extraction like gold mining and logging. And all of these things contribute to an increase in kind of the human interface with the forest that ends up resulting in greater malaria risk. And then, of course, if you followed what's been going on in Venezuela, there's been a lot of destabilization politically that has caused human migration across the region and is contributing to both resource extraction activities in other countries, but as well as just generally people migrating around and contributing to the spread of disease. So just to quantify what these are, in Colombia, you've seen a 200% increase in malaria. In Ecuador, there's been almost a 700% increase. And in Peru, there's been between a 200 and 300% increase. So our work is done in Peru. This is where we built and demonstrated the validity of our system. To give you an idea of the patterns of malaria over time, the blue is Vivax and the red is falciparum. The PAM-AFRO program, which was the Global Fund program to reduce malaria, was in effect between 2006 and 2011. It was highly effective. It reduced cases by around, I think it was around 150 to 200,000 cases total were reverted because of the program. We'll talk about that a little bit later. In 2011, when the program withdrew, there was a massive flood that caused roughly 80,000 people to be displaced from their homes, impairing the health system. And since then, there's been a rapid rise in malaria cases. There's also been concurrent dengue and Zika outbreaks that have been occurring in the Amazon. I'm sure you have read about those in the last couple of years because Zika obviously came to the US, I think in 2014 and 15 in Florida. So how is surveillance conducted? So you might be familiar with surveillance in the United States. We get these daily reports of how many COVID cases are occurring. We wish that malaria surveillance worked that way everywhere, but it's not even close to that competent. So the way surveillance generally works throughout all of the Americas is that it's a decentralized system. You have a system of health posts that exist across a region. This is Loreto, which is the largest Amazonian region in Peru where we did our work. It borders Ecuador, Colombia, and Brazil. The black dots are where the health posts are, and the tan orange dots are the population centers that were identified by the census. And then unlike, well, I wouldn't say it's unlike, but the way the health system is set up, they create these micro-reds, they're called, these micro networks. And then these micro networks are nested within larger networks of health system reporting. Those networks don't necessarily coincide with district or county level boundaries. They're defined by the health system, not by an administrative system. But basically, the person will come in, they'll get a malaria test at the health post, and then eventually that data gets transmitted up to a central system. Some of the problems with malaria surveillance are the fact that You have a lot of migration in the region. So do I have I'm sorry, I don't have a distance measure here. I just noticed that. The distances here are, so if this center right here where this big black set of dots is the city of Iquitos, has about 500,000 people. But going from Iquitos up to this first circled red dot is probably about 500 kilometers or about 400 kilometers. So just to give you an idea of scale. What happens in surveillance is that usually if you're infected with malaria, you go to your nearest health post. However, there's so much migration in the region, oftentimes people will get infected one place and they'll either get diagnosed in their closest health post or they'll go back to their home and get diagnosed in the place they live. So there's this disconnect between where people are infected and what environmental data are actually indicating whether or not something is related to that case. So this is an example of what a health post, the health system report looks like. They have the weekly epidemiological cases being reported. So hopefully you're familiar with that if you've looked at a COVID dashboard. But they have these weekly reports and these trends. And then they've got this breakdown of cases by different districts, which are equivalent to our counties in the Amazon. And then they separate it out by incidents. Well, in this particular map, they separate it out for what's occurring in the epidemiological week 4 versus what's occurred cumulatively for 2021. So as I said, the way the system works is that a person who has symptoms will go to a health post. They'll receive a microscopy test, which is basically they prick your finger, they put it on a slide, they stain it with a gizmo stain, and they look at it under a microscope to see whether or not you have Vivax or falciparum or any other types of malaria. Sometimes there's rapid diagnostic tests that are available locally, but basically only positive cases that are confirmed by microscopy are reported to the health system. This is very different from the case in Africa, where cases are often confirmed only by clinical diagnosis and not by microscopy or rapid diagnostic test. When a person is positive, the health technician will take data like their name, their national ID, the malaria type that they detected, their age, sex, location, etc. And all that gets put up into a database that's sent centrally to Iquitos and then centrally to the capital in Lima. And every country does the same thing. So Ecuador has the same system, Colombia has the same system, Brazil has the same system. The data are almost identical across all those countries, and the quality of reporting is about the same because they all require this slide confirmed positive cases. But what happens in the CDC Peru room when they see this data, so if today is time 0, what's happening is that they don't have an accurate estimate of what's happening in that week. What they actually get is a report, which is about a 4-week lag of the total number of cases reporting in a particular area, right? So they don't actually know what's happening in the last 3 weeks. They have some idea, but really not anything accurate to respond to. So this 4-week lag, which is surprisingly very consistent, whether or not you're talking about Peru, Ecuador, Brazil, means that the system is mostly reacting to outbreaks that might be occurring and not necessarily being proactive in responding to them. And the other point that I mentioned, that this disconnect between the transmission and reporting, and that occurs because of migration. And depending on the season at which you're detecting malaria, you can have anywhere between 10 and 40% of cases being disconnected from the location at where the malaria is reported. So the disconnect between the environmental determinant of the location of the health post and where the person actually got infected. All right. So how do we improve response and move towards elimination? So this is where Ben's taken over.
All right, thanks, Bill. So here's the basic plan, right? It's a continuum from natural systems on through human systems, and then also recognizing some feedbacks between human behavior and the natural systems, particularly at local scale. And so the way we frame this up, and this is all work that got started really with the support of NASA's Health and Air Quality Applications Program, which got us really focused on how can Earth observations be useful in this context. And so we used Earth observations in a few ways. What we're showing here on this slide are a couple of the major ways we did it, which is through a land data assimilation system that I'll describe in a moment, but also something we don't have time to talk about today, but has been really important, has been using Earth observation for land cover change classification across different scales. Very local scale change relevant to things like mosquito breeding habitats, up to larger scales relevant for things like transportation and identifying livelihood activities. All of that in the land data assimilation system, actually, can you go back for a second, Bill? Thanks. Then gets worked, gets combined with information from a human population model and goes into models that Bill will eventually describe, which have to do with actually predicting malaria risk. I will just note that there are a couple of different models that Bill will get into in a moment. Some of these regional and district scale statistical forecasts to go to Peru CDC to inform real-time risk monitoring and prediction. And then there are agent-based models, which we use in more local scale targeted analysis. And those models are really useful for understanding how interventions might be effective or ineffective in different contexts. And those also can be informed by Earth observations in terms of understanding at local scale how these feedbacks between behavior and risk run. Okay, thanks, Bill. Go next. So a land data assimilation system, for those of you who don't work with such jargon, essentially what we're talking about here is a system that integrates information from various Earth observation sources. And Earth observation, when we talk about that these days, colloquially, I think people picture like satellite images as being how you observe the Earth. We broaden that category a little bit to talk about observations that are directly from satellite, but also proxy observations from models, and the integration of the two with in situ measurements. And so in a land data assimilation system, you take landscape information, largely from satellite data, talk about vegetation characteristics, land cover, soils. You combine that with meteorological data. So we are not actually running an atmospheric model here. We are instead drawing real-time information from atmospheric analyses that we then downscale. And so we use satellite-derived precipitation and some analysis model-based meteorological fields that we downscale into our region. You then run a numerical model for, which I'll describe in a moment, just a hydrologic model. And as that model runs, you have the capability of ingesting new satellite data on states that you're trying to predict. Soil moisture or water storage, in some cases, vegetation characteristics, if you're simulating that. And that allows your product to be not just a model output, but really a hybrid product in which the spatial and temporal completeness of a modeling approach and all of its physical foundations is merged with the best observations that you can manage to obtain as the model runs forward. And then from this, you get estimates of surface hydrology and such. Okay, thanks, Gabriel. You can go. And so what is the model running for those who are into the details? We are using the NOAA multi-parameterization land surface model. There's a schematic here. It's essentially modeling surface and energy fluxes through the soil column and vegetation exchange with the atmosphere. We do that in 15-minute time steps. We drive it with these satellite-derived observations of precipitation. We're using the Global Precipitation Measurement Mission iMERGE product for that, as well as some other information of atmospheric fields from the Global Data Assimilation System. And we use satellite data for vegetation. Next slide. And then we combine that. So the NOAA MP model gives us estimates of soil moisture, which we feel are really relevant to breeding habitats and some other surface temperature conditions and fluxes. But then we use the hydrological modeling and analysis program, HIMAP, to route the rivers. So we also can get a sense of what's happening with inundation, flooding, high and low flows, which is obviously highly relevant on these communities that often, almost always lie along rivers. Next slide. And to give you a sense of what HIMAP actually does, this is modeling the floodplain so that we know not just is there a lot of water in the river or a little bit, but also what's happening in the floodplain on the margins of the river, where you will, under certain conditions, get breeding habitats forming, and other conditions see breeding habitats get washed out by large flows. Okay, next. So we run this right now. We've done it a few different ways for Bill on different projects. Sometimes it's 1 kilometer, sometimes it's 10 kilometers. Here we're doing it at 5 kilometer resolution in order to study this kind of regional scale, multi-country analysis, though we do go down to 1 kilometer around Iquitos. just showing here an example of an output. This is a standardized soil moisture anomaly from a particular time just after a big El Nino had come through. And so you're seeing really wet conditions along the northwest Peruvian coast, as is typical of El Ninos, and a kind of a residual drought over the Amazon, again, typical of what you'd see under those conditions. Next, please. And just to note that we are assimilating or have the capability to assimilate various satellite fields to really leverage these Earth observations to enhance our estimates, because this is a very data poor region. Bill talked about those complications from the health perspective, also true from the climate, hydrology, and ecology perspective. Great, next. So yeah, just some examples of what this looks like. Okay, so the boxes here, which are places that Bill might talk a little bit about when he gets back into the malaria risk, but various parts of the Peruvian Amazon that we're interested in understanding from the perspective of malaria risk. And you can see how you can track your meteorological anomalies, these downscale temperature fields, your satellite-derived rainfall, as well as your hydrologic predictions of something like soil moisture, all perhaps relevant to the disease process. Next. Great. So I'm just briefly, can I kind of emphasize the Geohealth connection here, right? As you're probably inferring from the way we're presenting this, this is a case of really multidisciplinary collaboration, right? Where Bill's bringing the epidemiological expertise, I'm trying to bring the physical process expertise, and we're coming together. So it's not just the one group's doing this; it's really a cross-group effort. And so just to emphasize a little bit about the responsibilities for those of us coming from the physical climate science side. It's great you can do these in data poor environments, right? But you need to evaluate it on its own terms and also with respect to the prediction targets of the malaria system. So just really briefly, I'll show some work that my student Christina Ricalde has done to do just this. And you're looking at here, don't worry about the text, but you're seeing different ecological regions across tropical Western South America that has these gradients that go from the coast through the mountains and on into the Amazon. So we can move to the next slide. And just show here, again, this is kind of like to convince you, on one hand, convince you that this is a reasonable way to do things, and on the other hand, to show you that there's these uncertainties. So what we're showing here is the satellite-derived precipitation, okay? And you're seeing a comparison between the orange box is showing the model and the blue box being these observations that we got from the Ecuadorian Meteorological Service. Another key collaboration, right? You need to be working with the local partners to get the data. And if you look at this, I would like to convince you that we get the seasonality pretty well. The biases aren't terrible, but there are in certain ecoregions some evident biases in the satellite precipitation that indicate that we might need to worry about being a little too wet or too dry in some of these regions, and that uncertainty propagates to the entire prediction system. Next slide. And another kind of put in here as a case in just a demonstration of how you do this. You don't have great observations of a lot of the parameters you're trying to predict, right? So here what I'm showing you is soil moisture content, and we do not have a dense network of soil moisture measurements across the Amazon, or really almost anywhere in the world, right? So this is another place where the Earth observation is taking our satellite data, in this case, a European Space Agency harmonized soil moisture product, shown here in the gray boxes, and comparing that to what our model is saying can help us understand where are we doing okay in capturing seasonality, what kind of biases do we have, and where might we have problems. And I'm not going to take the time during this webinar to go through the details of this, but if you just even glance at this, you'll see there are a couple places where the seasonality is not right in the model, right? And other places where the seasonality is right, but the magnitude's not right. We're missing extremes. And so all of this has to be considered in the propagating uncertainties of the prediction system. Next slide. And this is just looking here now, I believe, at the stream flow. Sorry, just one more example of how you need to work with your local partners to get in situ data, often not publicly available, in order to evaluate. And here you start seeing some bigger problems in the model. And this is not surprising as anyone who works with these kinds of models or hydrology in general would appreciate. We're talking about evaporation-dominated environments here, right? You have most of the water that falls as rain evaporates. And so then when you try to find that residual that's going to end up in a river, you're looking at the residual of big numbers, that's a smaller number. And so it's not at all uncommon to see that in certain basins, we see pretty big biases. And that can be because of the reason I just described. It also can be because of difficulties in simulating the flow paths in a complicated hydrologic system, such as the Andes escarpment into the Amazon. So just fair warning on that. And Bill, I think I'm going to pass it over to you now, right?
All right. Thanks, Ben. So So as you heard from Ben, we have two ways of modeling and combining the LDAS data and the malaria surveillance and population data. They work jointly. One is kind of an aggregate way of looking at what's happening, and one is trying to be more focused and downscaling the early warning system data. And the reason we do that is having these two scales is basically because we know that at the larger scale, we can kind of capture some of the noise that is occurring due to people traveling around in different areas and not being connected to their environment, that we're measuring and comparing to their risk of malaria. So we call that approach the EcoRegion forecast model. So we define these ecoregions using kind of like an ecological niche modeling approach, which is basically a factor analysis using LDAS data, land cover data, as well as some population data that we have on the ground. And then we defined ecoregions, and then we applied a model. And then we have a district level forecast that takes the conditional probability that the ecoregion detects a particular outbreak, and then predicts whether or not at the district level we are seeing a similar effect at the smaller scale, meaning a similar probability of I'm sorry, not a similar. We're calculating the probability of whether or not an outbreak will actually occur at that district. So let me show you how this works specifically. Some details. So basically, we have this ecoregion model where we combine a bunch of the LDAS data, land cover, an ecoregion model from NatureServe, and we stick this into a factor analysis. There's different ways of doing this. We don't take it at one time point. We took it at we kind of use a time series factor analysis approach to define these different ecoregions. But basically, we pulled out 4 different factors that defined variation in levels of temperature and rainfall, divisions between primary, riparian, and anthropic areas of forest, and then other kind of bodies of water and rainfall that are kind of defining the regions. And then we kind of combine all of those different, those 3 different factors, and identified 7 different socio-environmental regions that are distinguishable by population size, the amount of flooding that occurs in the regions, the amount of temperature variation, humidity, and soil moisture, things like that. And then what we did is that we took all of the malaria data from the health posts that are occurring in each one of these ecoregions, and we constructed a new time series, right? So instead of using the district or the health posts time series, we constructed the ecoregion time series. And what we found was that based on other malaria data that we've had in the region, looking at migration and land use change and land use decision making, we found that generally people stay within their ecoregion when they are doing logging or fishing or mining. So they're captured within those ecoregions. And we also see that there's very similar ecological characteristics predicting where different mosquito vectors exist within the ecoregions, so that we have a kind of a strong argument that within these ecoregions you have this very similar human environment interaction, as well as similar ecological characteristics of mosquitoes that might contribute to transmission. Then we had we experimented with different ways of modeling this data. We did everything from a machine learning algorithm to Poisson models to distributed lags, and surprisingly, this approach turned out to be the best. It's called an unobserved components model. You have probably never heard of this because it's an econometrics technique. I came across this mostly because I was looking for different ways of specifying time series models using this data. And this one came up as a way of modeling stocks and, doing forecasting of how much money you might make from the stock market. So if you want to use this model to make money, you can do it as well, because it's actually made for that. But basically, this model is it's a basic time series where you've got your outcome defined by whatever malaria rates you have at the particular week. You're modeling a trend over time, a seasonality component, something that's occurring cyclically, and an autoregressive component. And then you can add in an autoregressive term, which is kind of the time series model. You can add in explanatory variables like the LDAS data over time. And then, of course, you have this just white noise error term. And the great thing about this model is that this was for one particular ecoregion, for ecoregion 3 that is along the border of Colombia and Brazil. The dots are the actually observed data for each each epidemiological week, and then the solid line is what the model is predicting. And then if we forecasted forward, if we cut off the last, say, 12 weeks of data, and we say, let's do a forecast. This line represents the forecast with a 95% confidence interval, and the dots are representing what was actually observed during that period. So the model did an excellent job in actually predicting how many cases were actually occurring within the ecoregion. And then looking at another ecoregion, this is along or near the city of Iquitos. The model is doing very well in predicting the trends over time for over this, say, 12-year period. And then in the prediction time, you have the observed number of cases kind of going up, whereas the predicted line is actually much below the observed. You might think that this is considered a bad fit, but actually what's happening here is that these dots that are following outside of the 95% confidence interval actually are considered outbreak periods, right? So in this particular example, we would say that if August 26th is today, and we ran this model, and we observed cases kind of exceeding those predictions, that would be considered what an outbreak would be occurring. So just going back to, this is what the health system sees. This is what a forecast might look like. You have a predefined outbreak threshold. So whenever your model 95% confidence interval overlaps with the outbreak threshold, you claim that those are periods of time at which an outbreak could be occurring. And then when we run this model repeatedly from 2016 onwards, we could actually calculate how sensitive the model was in actually predicting whether or not an outbreak was going to occur, calculating the sensitivity and the specificity. And what we find, at least from the ecoregion, we get extremely high levels of sensitivity and specificity. The numbers here are actually low because we did this on a month-by-month. Do we do this month by month? No, we did this week by week, but I think we only ran it for 12 months. So we only have something like 13 observations or something like that. So we don't have a huge sample size in this particular table. But let me show you another, we ran this again at the district level. And the district level works with a hierarchical Bayesian model, which it's basically a logistic model with using some kind of conditional prior, an autoregressive prior, if you're familiar with how Bayesian actually works. But it's the nice thing about Bayesian models is that unlike the unobserved components model, which we are converting to a Bayesian unobserved components model, the Bayesian model will give us a probability that an outbreak will occur based on a posterior probability in a particular district. But you can set up the district level model the same way. You have your logistic model for the probability of an outcome, you've got your set of covariates, and then you've got this spatial temporal random effect that's in the model. I'm not going to go over what the advantages and disadvantages are, but basically I will mention that the outbreak thresholds that I was showing on the previous slide, we don't define those. Those are actually defined by the Ministry of Health. And the way they define them is that it's a 5-year geometric mean for that epidemiological week. So if we're in epi week 12 right now, they take the last 5 years and they calculate the geometric mean of cases that occurred this particular week, and they put a confidence interval around that. And if you are 1 standard deviation above or 2 standard deviations above the mean, they will define whether or not we are in a warning state for an outbreak or an actual state of an outbreak. So for the district level, this performed very well as well. And we ran sensitivity and specificity from 2007 to 2019, doing 8-week district forecasts. And we did this for one district that is along the border with Brazil, and then one district that is right next to Iquitos, which is the major city. And what you can see is that this is just a root mean squared error, showing the error from what was actually observed to what the model was predicting. And we actually do extremely well, with an exception being in 2017, when there was some weird anomalies with malaria rates going on. But along the, I'm sorry, actually this region, this top graph is actually the one near Iquitos. This bottom graph is the one near the border. The one near Iquitos, we actually get very close to the mean, whereas along the border, we slightly underestimate what's actually happening. And I can tell you the reason why that's occurring is because people that are working along the border and live along the border, they have more, there's much more porosity in terms of people going to Brazil sometimes to get tested and treated versus staying in Peru. And so we think that there's a lot of lost cases that we don't capture in our system, which is why we are proposing an expansion into Brazil and into Ecuador so we can capture those cases a little bit better. But regardless, we calculate sensitivity and specificity of these tests, or of these outbreaks, and we still perform very well. So around Iquitos, we're getting between 75 and 95% sensitivity, and equally high specificity. And then along the border, it's worse, right? So we get around 50 to 60% sensitivity in terms of predicting the outbreaks, but the specificity is not so bad. This shows you the overall performance of the models, where we're performing well and where we're not performing well. The one district that stands out is this dark red or dark purple district. This is a district that is along the Ecuadorian border, and I think we show you in an example about the spillover of cases between Peru and Brazil. But there's the Ashwar and the Shawar indigenous groups that live along this border area, and there's constant travel between that border, between communities. And they don't, they're family members, they're really well connected, so there's not a lot of controlled migration, because they're allowed to travel freely along the river. But that just means there's a lot of importation and exportation of cases that are occurring, which is another reason why we have to do a better job of predicting what's happening along the border. All right, so Ben also mentioned the other model that we're running in this system. This is an agent-based model. We actually created the first agent-based model of malaria in the Amazon, and it was one of the first agent-based models of malaria ever published. And if you've ever run these models, they are quite complex in terms of building a set of rules for the agents that exist. So the way an agent-based model works is that you basically have whatever agent of change that you're defining, and you are defining a system of things that agent is connected to, and a set of rules on how the agent is interacting within that system. So in our particular case, we have a system of rules for mosquitoes, we have a system of rules for the Plasmodium parasite, and then we have a system of rules for humans. And you set up this model so that each agent is acting independently of the other agents, but then you have to overlay them on top of each other to figure out how many people are actually being exposed to mosquitoes, which humans the mosquitoes are feeding on, and where malaria is being introduced and spread. And so we ran this model. We have several publications on this now. This is just our first one where we were showing a demonstration that the agent-based model actually does a pretty good job of modeling the seasonal variation of malaria in specific, in riverine communities in Peru. So these are, I didn't put down the what these lines mean, but these different lines are different scenarios, I believe, for inputs. And I think the dotted line, I think the black line is the actually observed malaria cases. So we were doing quite a good job of predicting malaria. And then we could, based on modeling where these agents live, where the humans live, we can calculate, where in the community risk is highest. And these are just basic spatial statistics you can run. All right, Ben, over to you.
Okay, so let's talk a little bit about how this is actually coming into practice. Okay, and there's going to be some challenges presented here. Get a few examples that Bill has really led, and I've been involved with on trying to influence policy, largely in Peru and then with other partners. So let's just start in on the next slide. So first point, Bill talked several times about these border dynamics in passing, and so that's a real challenge certainly in this Western Amazonian region. And so when we talk about malaria risk factors and potential for control in different countries, you have to think about how the border is involved. So this is a paper that was led by students. See the 5 names there of students working across all groups in order to look at how malaria transmission across the Peru-Ecuador border was leading to enhanced risk in Ecuador, Peru being the source region, and then it's spilling over into Ecuador. And so this was an example where we were able to use our analysis and modeling tools to inform an analysis of risk factors that then in turn can be used to adapt different strategies in the different countries. Next slide. And then Bill talked earlier about the incredible successes of PEMAFRO, right? This attempt to actually reduce malaria that then was discontinued. And so a question could be asked, well, what's the counterfactual, right? What if PEMAFRO weren't there? Can we really establish that it was the program that was responsible for the success? And once you have this kind of modeling system in place and you demonstrate out of sample scale as Bill has done, you can then look back and say, okay, well, let's look at the actual observed cases during the PEMAFRO period and compared to what we would predict based on our skillful model, and then quantify the health benefit of the intervention, right? So I think this was a really useful and powerful demonstration, both of the capabilities of the system we developed, and perhaps more importantly, really being able to quantify the value of the rollback campaign. Next slide. Great. And then this is just another example of that, right, Bill?
Yeah, this is just showing it's the same thing you said, but the first slide shows how many cases that PEMAFRO prevented, and this slide shows the failure of the withdrawal, right, from not having a planned handoff of the intervention system. So,
yep, the good and the bad.
Yeah,
yeah. And then the team went and several times has held meetings with the Ministry of Health in Peru, which has come with its own challenges on account of turnover in that department and in the Peruvian government in general. But we were able to show these results to high-level officials, indicating, and these are different examples of some of the plots that Bill showed earlier. You remember those colored plots of the dots versus the lines and the blue uncertainty range, looking at what the predictions were telling us in various parts of the Laredo state and the Amazon. And so again, being able to present these and demonstrate their potential value for decision makers. And here it was just some examples of those results with some of the forecasts and therefore the sense of where there were places with elevated risk that required potential intervention. Great. And then as we all know, the past year has been incredibly challenging. Right? And so as one might have expected, you saw a massive reduction in reported malaria cases in 2020. And this, we all assume, was largely due to lack of surveillance. So clearly there could have been behavioral changes. The cases might have dropped because of COVID-induced changes in behavior, but also they basically shuttered their primary healthcare system. Right? And so therefore you weren't able to get those data. So one question is, well, how many cases do we think really happened? And again, here we've got a situation where we can play that counterfactual, just as with PEMAFRO. What do we think, given our understanding of climatic, hydrologic, ecological, and other covariates, should have happened in 2020 versus what was reported? And so as you can see here, the malaria early warning system estimates are on the order of 3 times higher than what was observed, and we attribute this largely to reduced surveillance, though one would need to separate between the reduced surveillance and any real change in caseload that did result as a factor of changing transportation patterns and such. All right, and just in closing, talk a little bit about the challenges associated with implementing and operationalizing a system. So here we have a real opportunity, thanks to our international team, to not just build the system and show it to the vice minister, but to actually get implemented, running operationally in our target countries. And we focused on Peru and Ecuador, where we have the strongest partnerships. And we had a great setup, right? They've been looking at this with collaboratively presenting these results to decision makers, and lined up a crack team of folks who were going to transfer the entire system, the land data assimilation system, the statistical models, everything, to run them operational in these countries. And these are some of those good folks who we were communicating with about doing this, getting the visa applications through, et cetera. And then, right, nice animation, but I didn't know it's going to spin like that. And so what ended up happening? So, okay, so the red X's don't mean that they died. The red X's mean that they were otherwise occupied. Because what happens is life moves on, right? And so we had this training plan, but then when all plans fell through and the project had to be delayed, folks had to do other things, right? And so a couple of our talented collaborators, good for them, moved on to do additional education, right? But we lost that window of opportunity to get the transfer with those folks, and then others had to move over and work on COVID. And so we were intercepted, right? And so then this requires that we revisit our plans for transfer. And I think this is a challenge that anyone who's worked on such kinds of operationalization anywhere, but particularly when you're trying to do it internationally, can appreciate the challenges of having a stable team all the way through to the end use side. And so then this is a new strategy. And Bill, maybe I'll hand it back to you, since this is a strategy you've really envisioned.
Sure, thanks. So what we're planning on doing is we've created a new partnership with the Inter-American Institute for Global Change Research. They're based in Uruguay, and they have a mission. It's an intergovernmental agency, and their mission is essentially to improve science knowledge of policymakers across Latin America and the Caribbean. They have legal agreements set up with 19 countries in the Americas. They're very well set up to do climate and health related research, as well as just environmental change in general. So we came up with this idea of a new program called ASARCAR, Malaria Elimination. If you speak Spanish, you know that ASARCAR means to bring together, but it actually is an acronym that stands for what does it stand for? A consortium to effectively respond to climate attributable risks. And so the way we envision this is, instead of trying to implement all of these entities in within the government, we are going to put all the technology and all of the expertise of the LDAS and the statistical models within IAI in Uruguay. They're going to run everything across as many countries as possible that we can get data for. And then we're going to set up and develop a societal adoption strategy where, if you're familiar with science diplomacy or the AAAS program with the Science Policy Fellows, IAI has actually created a new program that's modeled after that, called the STEP Fellows Program, where they place recent PhDs mostly in institutes within government, ministries, and have them working on specific topics related to food security, climate change, resilience, things like that. So we're gonna design this so that the technology piece is going to be running completely independently, but then we're going to be training and using these STEP fellows to basically be our representatives within ministries of health, within the health network system across different countries, to get people to understand what the system is telling them, and then also how to use it, how to respond to it, how to connect to it, and then also get feedback from them on how to make it better, especially at the community level where this will be a website eventually. And since this is a decentralized health system, communities and districts can actually operate independently. So they should be able to respond to predicted malaria outbreaks in their area. And so we want to make sure that if we are communicating something incorrectly, or if they see something that they're either questioning or not sure about, we need to know about it. Because one of the main things about having a system like this is that you have to build trust, not just at the national level, but at the local level, to make sure that people believe what you're telling them is actually at least close to true. And then, we have other things with the network, but it really kind of depends on whether or not we get this kind of larger level of funding that we're applying for. But it includes things like seed grants and fundraising and things like that. But basically, if that plan actually gets funded, I think it will be highly effective, and it will be a lot of fun to work on, actually. And hopefully it will keep growing. And if you're interested in getting involved, of course, we will need people. But just to kind of summarize, we have developed this early warning system. We have shown that it can produce 12-week forecasts and forecast outbreaks with more than 90% sensitivity fairly consistently. We have strong government partnerships, but we also recognize that the government partnerships are also limited in the capacity to actually adopt technologies. So this is why we've developed this new strategy for adoption. We know that COVID-19 has placed some major challenges to health systems in Latin America. We know that our system, even if it was in place, probably wouldn't solve all of the problems that they have. But I would say that the use of dashboards or early warning system type data presentations were not the norm in health systems in Latin America prior to COVID. It is becoming more acceptable now to use this kind of presentation of data. Even just mapping the data itself is something that is new and novel in many places in Latin America. So this is something that's changing, and we think it's changing for the better. So anyway, I think that's all we have. I hope that was informative. I hope you guys enjoyed that. And I guess Ben and I are both welcome to answer any questions you have.
Thank you so much. That was really great. And I'm really excited to hear the questions that people have, because there's so much to talk about. So I'm going to turn the time over to Andrea so that she can pose those questions and hopefully get a great discussion going.
Yeah, thank you for the great talk. It was really, really informative. And we do have a couple of good questions that came in. So I'm just going to start reading them to you. So have you noticed differences in malaria prevalence along Blackwater rivers or within Blackwater river basins?
Yes, so that was one of the reasons why we actually did the EcoRegion model, because the whitewater versus the Blackwater does have a lot of differences. Generally speaking, black tends to be a little bit more soil. I believe it has I think it has slightly higher pH and maybe a little bit more soil sediment that's suspended solid. So generally mosquitoes like to breed in clean water. I wouldn't say there's huge differences, but there are significant differences between rates that have the kind of the black watershed areas versus the white watershed areas.
Yeah, thank you. And another one that we got coming in is, have you considered incorporating any short-term weather or sub-seasonal climate forecasts into your model?
You should ask. Yes, and so we're doing that right as we speak. The sub-seasonal forecasts are kind of spinning, and I think we're excited about this, right? So I mean, so much of this is about timeliness, right? And so right now, simply using the monitoring forecast actually is adequate to give a good forecast for malaria, right? Because of the natural lags in the system, let alone the improvement over the 4-week lag they're already seeing in the reporting data, right? So we're already getting ahead of things without a literal meteorological forecast. But right now we're developing a system that uses an ensemble of the GEOS 5 or the GEOS subseasonal to seasonal forecast that NASA generates. And we then kind of do a bunch of bias correction, post-processing, all kind of sub-seasonal forecast fun stuff that some of you know about in order to run it through and get Bill's teams, not just the monitored hydrologic conditions, but forecast out to 3 months hoping to get scale out to about 4 to 6 weeks.
Thank you. And then one question was regarding interventions and asking what concrete interventions would there be to reduce the impact on malaria locally based on your predictions?
So there's a couple different interventions. I actually deleted the intervention slide I had there because I didn't think anybody would care about them. Sorry about that. So there are a couple important interventions. There's indoor residual spraying, which basically means they go into homes and they take insecticides, which there's a whole question about insecticides. If you want to know about insecticides, I can talk more about it, but they take insecticides and they'll spray, ceilings, walls, under tables, things like that. There's bed net distribution and also insecticide treated bed nets that are distributed in different places or replaced for people who want them. There are improved screening for drug resistant malaria. So that's a surveillance that has been going on for at least 20 years. That was led by PAHO, that kind of started that around 2000, where they've been trying to monitor for different strains of malaria that are resistant to things like chloroquine, and now there's artemisinin, and different types of drugs that are being used for monitoring. But I would say that the biggest thing is the indoor residual spraying and the bed net distribution. There are some other programs like draining standing water areas around homes, but that's mostly that's not necessarily coordinated by the district. That's more of a recommendation by vector control units. If the vector control unit exists within a community or in a district, well, they'll tell the household owner to kind of drain areas. There's a lot of fish ponds that are used for farm raising fish. There has yet to be any kind of interventions for doing things like adding larvae eating fish in those fish ponds to make sure that it eats mosquito larvae. But that's something that probably should be considered. Those are probably the main ones.
Yeah, thank you. And then there was another question that is also somewhat related to intervention. So when your models you create those early warning models, and then do you, based on that, alert the health departments? And are there any emergency response systems or communication campaigns related to that?
Yeah, that's a good question. So I would say there is no protocol that exists anywhere in the world that tells a health system how to respond to a predicted outbreak, even the United States. So even if that's one of the challenges of our system right now, and one of the things that we proposed to do in collaboration with our partners with this new proposal is to develop a specific protocol on how communities and districts should actually respond to an outbreak. Like, who are the contact people? What's the first step? What kind of interventions do they have available? I see Justin Lana's on it, and one of the, he works for the Clinton Health Administration or Clinton Health Access Initiative, and some of the things that he has told me that they struggle with in Guatemala, which is a shared thing in Peru and Brazil, is that even if an outbreak were to be detected and the number one intervention that they recommend is indoor residual spraying, they might not even have insecticides stored locally to use them. So then they have to go and try to order the insecticides, and that can be a whole supply chain problem. So there are many issues associated with trying to get the right interventions deployed that are not just telling people, oh, you need to, you're going to have an outbreak, but if you tell people there's an outbreak and there's nothing they can do, then they feel completely helpless. And all of us feel that, right? Especially a year ago when COVID comes out and they tell us not to use masks at first, and then then that was a confusing piece of communication. And so you can imagine if you're constantly being told that there's a malaria outbreak that's going to occur in your community, and there's absolutely nothing you can do about it except for stay inside, that's not very reassuring. So there definitely has to be a supply chain discussion with partners on how to free that up.
Oh, thank you. There was one question that just came in about Vivax versus falciparum malaria, and whether you found any specific environmental conditions that are more predictive for one versus the other species.
I don't recall. I don't know, Ben, if you recall anything like that. I don't think we did.
No, in our models, we certainly haven't. I don't know if anyone's seen it observationally, but the models do not distinguish.
There might have been a slight difference in an effect size for a beta value, but it wasn't a significant difference. And I imagine that the difference we see is not necessarily a difference in that like rainfall or temperature might be impacting risk. It probably has to do more with the fact that if you get falciparum, you have to get the full treatment to be recovered. Otherwise, you have severe illness. Whereas if you have Vivax, you can take 2 days of treatment, even though it's a 14-day treatment, and you feel perfectly fine. And then 6 weeks later, it will come back. So there could be a little bit of noise occurring with that.
Yeah, thank you so much. I do see that people start dropping off the call because it is already 12:30. So yeah, I think we can with this wrap up the scientific question part of the session and move over to more like the early career related questions, because we do have a couple of those as well. So yeah, for anyone on the call who is not considering themselves an early career person, yeah, you don't need to stick around for the next 20 minutes or so. Yeah, and I think I'm just gonna keep going with some of the questions that were submitted from early career researchers or students that were curious about your career path and your field. And yeah, one of them is about, I mean, lately there's been a lot of talk about students. There are more graduate students than faculty positions and such. So there's a big interest in moving out of academia and finding positions out of academia. And one question is related to how can you make the transition from being a graduate student or being in academia to finding work outside of academia within this field?
So, you know, we happen to both be in academia right now. So I guess that there might be other people even in the call who can provide better insight than we can. I will say from my perspective, so I'm kind of in academia a little bit by accident. And there are lots of things you can do with a higher degree, whether it's a master's or certainly a PhD. And so, you know, certainly in my case, coming out with, you know, from the kind of the geoscience side of things, and as I know, I'm looking at the list of people here, many have already done, right? There's a lot of opportunities, certainly traditionally in the government labs, right? So there's research opportunities there. There are also programs like the LDAS Fellowship, which Bill alluded to in another context. I did that. Several other folks, I think, here did that or are considering it. And that's a great way to transition into something like a government or also non-government positions related to science, the interface of science and policy. So I think there are lots of opportunities. The other thing that I will say is that I've recognized as I've become a faculty advisor is that in the past decade, as I think most people here are aware, it's like there's been a revolution in the kinds of jobs available to anybody working on data sciences in general, climate data science and analytics in particular. When I finished my PhD, they're just like that. If it existed, I didn't know about it. It was tiny, right? And people were all talking about the fact that, oh, the insurance companies used to hire meteorologists, but they don't anymore. It's like, well, that's flipped, right? Now all of a sudden, like you've got all kinds of industries, new financial products, all, you know, it's become a very big field that is in real need of people. And I think probably many of the early career folks online can attest to the fact that there are a lot of people looking to hire. And that those, I would say, you know, so I'm, you can say, oh, easy for me to say because I've got the faculty job, but I definitely have envy for those other positions, right? Like, I mean, they are exciting, dynamic places, right? And so I think that recognizing that it's not like there's a hierarchy here coming through, right? It's like there are multiple different directions, all of which can be exciting and all of which really benefit from the skills you bring from your training.
I would just add on to that, you know, I have a friend of mine who writes a lot for CNN and these different like venture capitalist funds. His name is Eric Weirson, and he sent me an article that he wrote recently in Worth, which is I never heard of the article or the journal before, but apparently it's some kind of fundraising venture capitalist magazine. And the article he wrote was basically saying that, you know, if you are a research institute or a research, you know, NGO or university, there is an entire population of ultra rich people who don't know what to do with their money. They have made so much money over the last decade, and they are only giving at a rate of 2%, even though they've pledged to give up to 10 to 15% per year of their funds. And the reason why they're not spending it is because they can't find places that have big ideas and academics or researchers with plans to spend $100 million over 5 years or even over 10 years, which is an insane amount of money, by the way. But it's just to say that, you know, if you have big ideas and you want to go off on your own, there are places to try to fund big ideas. And I wouldn't say that you have to do that at an academic institution. You can start your own NGO. It's actually not that difficult. You can start your own LLC. That's not that difficult either. But it is to say that, you know, obviously academia and government are nice, secure jobs. But if you have some risk aversion, you can, or if you're a risk-taking person, that's definitely a place that you can look into.
Having too much money and not knowing what to do with it sounds like an interesting problem. We do have one question that relating back to your work and working with collaborators. So you already mentioned some of those pros in working with local communities, but what are some tips or tricks or lessons learned with forming these relationships? And I think specifically for early career researchers, it's often difficult to just come in as a graduate student and try to collaborate.
Yeah, I can tell you from our experience, the way we've created our community partnerships is basically just social networking, right? So you start with one person you might know in a country, which is what we did a long time ago, and you get to know people that they know, and you get to know people that they know, and eventually you build out a network of contacts. But it is time consuming. Obviously, these networks don't form overnight. I mean, the partnerships we have, I've been going down to Peru since 2004. When I was at Hopkins, I was going down to Peru probably 6 to 8 times a year. And basically it was all for, I mean, part of it was for research, obviously, but half of the time that you're doing research, you are doing socializing with partners and friends that you're making. And that's how you form your network. I would say that the funniest connection I ever had was we had, in our first malaria study, you know, I was basically doing mosquito collections with land use and land cover change and migration on the Napo River in Peru. And we were traveling about 200 or 300 kilometers upstream, interviewing people at different communities. But I had never been to these communities, and 2 of the field workers had never been to them. So we hired a boat driver who was previously an illegal logger who knew the river by the back of his hand. He used to avoid all the forest rangers so that he wouldn't get arrested. but he was well known in the community. He was well known across the entire river, and he happened to be the uncle of one of the field workers. So he agreed to come along and basically just introduce us to different community leaders, and that's how we formed those connections. It doesn't always have to be some formal academic connection. It can just be these really strange informal networks that form.
Yeah, and just to build on that, I mean, I definitely understand the perspective of an early career researcher feeling like you're not in a position to make collaborations, but the most important thing is time. And so I find that the projects that I've got the most satisfying collaborations on are ones where I made those contacts when I was early career. I was a little bit more able to really invest that time. And so, for example, the project we just described, I personally have no connections. Bill established them all. Then he brought me in at a time when we were all a little bit more senior. And I benefit from those collaborations, but I haven't been able to make those connections on that project, whereas some other projects in other parts of the world, as well as locally, are places where when I had a little bit more bandwidth, I was able to invest that time in those relationships. And so building these connections as an early career researcher actually is a great time to do it. And you have a lot to offer, and that can be student-to-student collaboration. It can be all kinds of collaboration, as Bill says, with like non-academics, but just people in the communities. You can really start to build some roots that will continue to improve your research as you get busier. Not that you're not already busy. I know you're already busy, but as more and more responsibilities impede your ability to put in that time.
Yeah, thank you. Those are some great insights. So yeah, another question we just got in is, how have both of your experiences been with promoting these multidisciplinary collaborations with health practitioners in the region?
You mean bringing in different disciplines to the stakeholders on the ground?
Yeah, I think that's what the question is. Yeah.
There's variable success in that. I would say that, in Latin America, if you've worked in Latin America before, if you go into rural areas, it wouldn't matter if you're in the Amazon or not. There's a weird hierarchy. First, when I go in, everyone assumes I'm a medical doctor. And when I tell them I'm not a medical doctor, I get put down a couple notches, right? Oh, you're not Dr. Bill? You don't have an MD? You can't treat my disease? Well, forget about you, right? There's also a hierarchy by sex, right? And unfortunately, men are higher than women. And that's something, if you're a female trying to navigate working in Latin America, it's a little bit different. I would say that, I don't think I can speak well about the best way to strategize if you're a female, but I have a lot of very successful female colleagues in Latin America that have done that very, very well. But, going into a community, even if I'm with, one of my colleagues who is an MD, and she is, much more knowledgeable about infectious diseases than I am, people will still come to me first because I'm the male and they think I'm a doctor. And they find that I'm not a doctor, and they kind of look at her and say, "Oh, you're a doctor. Okay, let me ask you the question then." But there is a hierarchy that you have to recognize. And so when you're talking about, say, bringing in climate change research, there is acceptance and there is recognition that climate is really important, because these people live with seasonal flooding all the time. So they recognize the importance of interdisciplinary approaches to living. So I don't think that's a problem, but I would just say the hierarchy of being doctors is different, and the hierarchy of if you're male or female is different.
Yeah, I just briefly, to build on Bill's point about people's familiarity and recognition of the importance of natural systems to their health, I think that's a big deal. And so I find, coming in from the climate science perspective, working with many communities, again, I don't work too much directly with the communities in this study, but some of the communities in East Africa and South Asia, it's actually very welcome, and you learn a lot in conversations with people, understand the connections between the natural systems and the climate and their health. It's actually a little more challenging for communities that have gotten further from the land, as they say, right? I mean, so when we do work on urban health and environment issues in the United States, that's where there's a disconnect between people's own perceived and real health priorities and what one can bring from an environmental perspective. You know, and I think people are recognizing it's important from an environmental and climate perspective, but it's not something that they are used to associating with health.
And then staying on the topic of working in this highly interdisciplinary field, do you have any advice for early career researchers regarding identification of funding sources within this interdisciplinary field?
It depends.
Depends
on
what your
base discipline is. I think that's always a challenge. I think I have this conversation with people every day about how to find an agency that actually wants to fund 3 questions that come from 3 different disciplines, and they view them as equally important. I just got off, I had a call with NIEHS on Monday about funding a technology for mercury capture. And it's incredibly important and incredibly impactful. But she said, if you can't prove a really strong health link, we're not going to fund it. And the point of the technology is not necessarily to demonstrate the health impact yet, but they don't want to fund it yet because it's not in their mission. So that's a hard one, I would say.
It is hard, and it's recognized as a problem, and people are working on it. So hopefully, we're already starting to see some change there. And there are some programs out there. I won't list them all that are pretty good, but you need to find one that works for your field. I will say that in my experience, part of this is why I think it pushes us towards these multidisciplinary collaborations as opposed to just doing it yourself as an interdisciplinary scientist. And I say that because it's hard, as Bill says, to find the agency that wants to fund your 3 critical questions from 3 different fields. But if you dig in deep on one of those, then it's a little easier sometimes. And so, I can, we first started working with NASA because I had some NASA experience. I'm like, hey, Bill, we can do this, and we're really going to focus on the LDAS, right? That's going to be the big thing, the land data assimilation system and how it can be used. And NASA's interested in improving the LDAS and showing its value. And so that can fund that part of it. And we don't talk a lot about some of the more nuanced health issues and research questions Bill has, but his team can answer those questions through the project. And vice versa, right? When I'm brought in on an NIH project, which I am, with Bill and other folks on heat and things like that, it's my excuse to have my team look at things like atmospheric dynamics associated with extreme heat events. I'm not going to tell NIH that, right? I mean, that project is going to be focused on the health questions, right? But then we answer the other questions as we go. So sometimes, seeking the funding opportunity that aligns with your diversity and balance of interests is not the easiest path, right? You find the questions that match the funding opportunity, and often that's easier if you partner with people that fill in some of your own personal gaps.
Thank you. We have one more question, and then, I think since we're almost at 1 o'clock, and then I think we can wrap it up. So the last question that got in was, speaking of, you're working abroad and experiences, how do you navigate being from a Western country with maybe a colonial history when you're working with these populations? How can you be mindful of these probably maybe hierarchical relationships?
So I think the question is directly addressing this decolonizing of global health movement that is occurring. What I would say is that the decolonizing movement is just revisiting the primary healthcare alma mater movement from the 70s, which people who got trained in public health before, I would say 2002 or 2003, when global health emerged, you had a strong component of community-based research, which is what I had, right? And you know, this movement back to decolonizing and recognizing it's important to listen to communities for a lot of people is kind of ironic, because that's what fundamentally public health was about. And you know, I would say that you know, we are always acutely aware of the power differential between where we're coming from a developed country, ultra rich country, and working in these communities where you know, a lot of them don't have running water, they don't have electricity, and we don't try to impose anything on them, and we try to get a collaboration with them to improve things that they want to improve. And you know, that's kind of like how we've always done our work in every country that I've ever worked in, at least. And I really feel like this decolonization movement, not to pick on MDs, but you know, global health movements in general has brought in a lot of people that are not trained in community-based research. And so decolonization is a way to kind of make everyone realize that, yeah, that's an important thing to remember.
Yeah, I think that's well said. And so I'm not squarely in the global health conversation, but obviously this applies across disciplines. Just to maybe complement that statement, I think that I find right now that some of these conversations get confused between the difference between Western country versus your in-country partners, and then the question of the communities versus the researchers, right? And both are going on, right? But I mean, so with respect to the first, like working with partners in other countries, I think that you know, I would hope, and I certainly hope that in my experience and in others, that there's not that much of a power dynamic going on. Yeah, sometimes the funding comes from the West because that's where the money is for a project. But if you're working with an academic or medical expert in the country with amazing depth of expertise, that's a partnership, right? And I feel like in my experience, people have been pretty comfortable to understand that, like, whatever currency the checks were written in, like, that's not what's relevant. What's relevant is the equal partnership. But that working with the communities, Bill already spoke to it, so I won't reiterate it, but that's, to me, has been the biggest deal. And I actually find it sometimes more challenging domestically than internationally, maybe just because of the embeddedness that we all have in our own cultures and the challenges that we have. When you're international, there's kind of a gap, and I would say cultural gap operating that in some ways makes it a little easier to be at ease, I think, with each other, because you're just looking at each other as from different places, as opposed to working with communities who are from the same place and yet have very different lived experience.
Yeah, thank you so much for your insights here. Yeah, so I think this is about a good point to wrap it up. So just somebody asked if you have maybe a link for your research where if people are interested in it, they can read more into it. If you can, yeah, if you have a website or relevant publications that you could put in the chat maybe. And then I just have a general reminder for everybody that we have an upcoming webinar next week, next Friday, on how to convene a session at the AGU fall meeting. So that is aimed at students and early career researchers who, yeah, want to propose a session for the fall meeting. Yeah, and then I think Jen, you had some final words to wrap up.
Sorry, I just want to thank everyone for being here, and especially for Bill and Ben taking the time to share such important work with us. I think it's really amazing to kind of see that, you know, kind of the purpose of Geohealth with the earth sciences and the health portions coming together in a pretty remarkable collaboration. So I want to thank you guys so much for that. And yeah, just another plug for next week's seminar, and then we'll be sending out additional ones throughout the year. And yeah, it looks like Ben put stuff in the chat.
Yeah, there's a little in the chat. We'll keep working on that, but and follow up with us directly, of course. We would love to talk to you. But thanks so much, Andrea and Jen, and all for the invitation. This has been fun.
Yeah, thanks a lot. This has been good.
Yeah, and thanks to the AGU folks who helped us out.
Absolutely.
Happy to help.
All right, take care.
Take care.
All right, bye everybody.